taking you through some housekeeping slides. Just for your information, the webinar is being recorded, and that recording will be made available as a resource on the MCQIC web pages shortly after we're finished. Next slide, please. And again. So, housekeeping. As always, can you please mute your microphones for the duration of the presentations, just to avoid any background noise. And also, it's helpful for the presentations if you keep your cameras off, just to avoid any connectivity issues. However, we're going to have a panel-led Q&A later on, and we'd really encourage you to switch your cameras back on and really be part of the room. So we'll stop sharing the slides, and we'd really like you to switch your cameras on and join in with any discussion. Next slide. And again, as always, this is an interactive webinar. We really do encourage your participation and your engagement. So we really want to hear your thoughts, your opinions, any questions that you might have. So to share your thoughts and opinions and questions, you can either pop some chat into the chat box, and I'll make sure any questions get called out, or otherwise, feel free to pop your hand up, switch your camera on, and speak to our panel directly. Next slide. So at the end of the webinar, we're going to have a wee short evaluation. So it'll be accessible through a QR code. So you can have your smartphones at the ready. For those of you who don't have your smartphones, we'll share the link to the evaluation in the chat box. So if you could fill that evaluation in at the end of the webinar, we would be really grateful. Next slide. So we're going to start recording, and then without further ado, I will hand you over to our chair for today, Lynsey.
Thank you, Damien. Good morning, everyone. And just echoing Damien's thoughts this morning, thank you all so much for taking the time to join us on today's Wellbeing Package webinar. For those of you who do not know me, my name is Lynsey Still. I'm a neonatologist in Glasgow. I have quite a privileged role in working cross-site between the Princess Royal and the Children's Hospital in Glasgow, and have been recently appointed as the neonatal clinical lead. So this is my first webinar, and delighted to see so many of you joining us, and hopefully we'll get some more joining us as the time goes on. And really privileged to be in this role to help steer improvements across neonatal care in Scotland, and at the same time delighted to be able to work with you all in doing so. So I'm just going to take control of the slides, and then we'll get things going. So today's agenda, I'm just making sure everyone can see those slides progressing. Yeah, thank you. So the agenda for today is giving a little bit more background and bringing into context the need for the webinar today, and bringing perinatal optimisation back into focus. We're also going to hear from quite a few boards across Scotland into the work for the Wellbeing Package, and looking forward to hearing about their successes and their challenges. We will then have a panel-led Q&A where we welcome input from all boards across Scotland, particularly those that didn't have the opportunity to present, and look forward to kind of learning from those discussions. And then we'll bring together the key themes for success of the Wellbeing Package work and the next steps for MCQIC. So what we would like to do, as I said, is bringing back into focus the importance of perinatal optimisation, and trying to look at a way how we're really standardising and reducing variation across preterm care. We want to try and highlight the successes and the challenges of the Wellbeing Package, and try to get into context where we're going with the package, what are the next steps in further improving outcomes for these tiny and vulnerable babies. So thinking about the background, so I'm sure absolutely everyone in this call is very much aware of the concept of perinatal optimisation. And this obviously refers to the delivery of the numerous evidence-based interventions across the entire perinatal journey, antenatal, intrapartum and neonatal interventions that are absolutely vital in improving both the short and long-term outcomes for our preterm babies. Many of these individual elements have been adapted and embedded in practice for some time now, but it's really more recently that these principles have been brought together in a package of care, and that's something that's been really important in neonatal care over the past few years. There's been evolution of the Wellbeing Package work since its launch in 2017, with lots of other fantastic work across the UK, including BAPAM's fantastic toolkits on antenatal optimisation, and Sarah Bates, Karen Lloyd and Tracy Kay's work down in the southwest of England and Preterm, all of which are very much focused into collaborative working to improve the number of babies being exposed to these interventions, and therefore improving outcomes. So the timing of this webinar is very apt, and I'm hoping the population on the call today has seen this data. So this is the most recent published data from Public Health Scotland regarding neonatal mortality across Scotland. And we are sadly seeing a couple of spikes in recent months, back in September and then again in March, out with the upper control limits. And although we don't often have to respond to outlier points, if single data points, there's also a shift upwards in the trend in mortality. So this is obviously showing quite a worrying trend within our neonatal population. So MCQIC and Public Health Scotland, Scottish Government and the network are all working together to look into this further and trying to find a way to formalise a response to these slightly worrying trends. As we try to establish more details surrounding the most recent data, it's important that we understand the context in which we are working. Obviously, over the past 2 years, it's been an immensely challenging time across neonatal and maternity services, as we all feel the extreme pressures across the piece. In addition to the very challenged landscape that COVID has brought, we also need to understand the impact of the extreme preterm population on this data, now that we're resuscitating down to babies at 22 weeks. When we look at the spike back in September, there was certainly a huge cohort within the extreme preterm population. The spike in March seems to be less attributed to that, but as I say, we're further looking into that in more detail. But we need to think about this in the context of rising mortality. And overall, we know that prematurity has a huge impact on infant mortality as well. So this is why we need to really work together to try and improve outcomes within this period. So when we think about the wellbeing package, what have we achieved and where are we now? So I'm just going to take you through some of the aggregated data for all the units that submit their data into the MCQIC spreadsheets. So first of all, we start with babies born in a level 3 tertiary NICU, and these are the babies born at 27 weeks because we know that there's a significantly improved outcome if you're born within those tertiary centres. Mortality can be reduced by at least 50% if born in the right place at the right time. We previously had a median of 100%, and we've started to see a slight dip in that, perhaps due to the evolution of best start early adopter pathways. So this is something that as best start evolves, we might have to look at even further and trying to look at those particularly optimally timed transfers to make sure these babies are born in the right place. When we look at antenatal steroids across Scotland, although our rates in general are very good for steroids given at any point in pregnancy, we're still getting women given just 1 dose prior to delivery and still getting women that have had exposure to steroids greater than 7 days. So we really need to look at this as an area to focus on to try and make sure these women and babies are getting the benefits from steroids within 7 days so that the babies can have the maximum benefit from these interventions. We wonder whether, although we've not had huge improvements in the past few years, we wonder whether potentially the implementation of QIP, hopefully across the country, might help with more timely steroids, because we are starting to see a little bit of trend around about the time that the QIP Act was introduced. So we're hoping that more and more units are taking this on to try and make sure that these women are getting the steroids a bit more timely. So this is a lovely slide for you to see, I'm sure, the successes of magnesium sulphate across Scotland, and certainly the message is clearly getting out there. Those conversations are happening, the communication between teams is clearly happening, because more and more women are getting their magnesium sulphate at less than 30 weeks. I'm delighted to see back in March that 100% of babies were given, eligible babies were given magnesium sulphate. So that's fantastic and well done to you all. Next off, deferred cord clamping, which I think is another key area of success within the package. And when we look at variation across the UK, we see that a lot less in Scotland, which is really fantastic to see. I'm aware that some units in England have very low rates of DCC, and we're trying to look at reducing that variation, but thankfully our baseline median rates are really pretty high. And in the past few years, we've seen a rise up to almost 80% of all of our babies being exposed to those benefits of at least 60 seconds of DCC. So again, fantastic efforts, and please keep up the good work. So achieving normothermia. So this has been quite a challenge across neonates for the past few years, and despite probably lots of work into temperature, we aren't seeing huge shifts upwards in a median of around about 80% of normothermia within the hour. And I don't suspect those babies are all coming in cold that aren't achieving that. I think probably more babies are coming in that little bit hotter now because we're all paying particular attention to it. So I think it's definitely achievable to try and get a little bit more improvement in this area, and hopefully we can hear a bit more about those successes today. Caffeine doesn't really need a huge amount of discussion. We're all generally very, very good at caffeine, and it's just keeping that message out there to not forget caffeine because it has huge benefits both in the short and long term. Maternal milk. So again, a slightly more challenging area that we're seeing across the piece. And over the past 12 months, we're seeing a bit more of a downwards shift in the amount of babies being exposed to breast milk within the first 24 hours. I probably can speak for our own units to say that COVID has probably had quite an impact on that with our staffing challenges and pressures over the past few years. But again, this is definitely an area that we hope that we can work on further. So I hope that provides a bit of context to where we are, the importance of our work ongoing. And I'm now delighted to go and introduce our first speaker today of our board sharing. So we're going to hand over to Augusta Anenih, who is a consultant neonatologist and lead for QI within NHS Lanarkshire and Wishaw, and she's going to chat to us about their work in the perinatal wellbeing package in general. So thanks, Augusta. I'll hand over to you.
Thank you, Lynsey. Yep, just taking control. So welcome everyone. Thank you for giving us the opportunity to share our work in Wishaw with regards to the perinatal wellbeing package, what our successes have been, our challenges, and what we plan for the future with this. So I'll just crack on. I'm sure everybody is aware of this slide. Beautiful presentation by Lynsey, kind of summarizing what the perinatal wellbeing package is. I'm not going to go through all the elements, but there are seven elements or so, and which, like we said, improve the outcome for our babies when they're carried out properly. So within Lanarkshire, our aim was through collaborative working with between the neonatal maternity teams and parents as well, we aim to achieve an 85% compliance in delivering all the elements of the perinatal wellbeing package. And I think this is particularly pertinent now. Our overarching aim was to achieve a 15% reduction in neonatal mortality within our local unit, but in keeping with what the Chief Medical Officer had kind of aligned with at that time across Scotland, contributing to decreasing that mortality across board. I quite like this slide. This is the quality improvement journey, which has been clearly kind of delineated by NES. In reality, for us, even though we've gone through all of these steps, the opportunity to go backwards was what was more useful to us, and that contributed to lots of our successes, being able to revisit every step we have gone through. So in creating conditions for change, in understanding our systems, and moving all the way to spread and implementation and spread. However, at each of these steps, the main areas of successes lie within, I would say, within these four main themes, which are the people and teams within Lanarkshire, the processes that which we had in place, the culture and mindset, and finally the data. Now, I was going through the culture and mindset. Obviously, we know the neonatal world knows that this bundle of items done together will improve outcome. But how did we work within Lanarkshire to get that message across, to let people buy in? And I think success lay here within making sure, showing a shared purpose, using patient stories to show what the outcome have been between babies who have had different journeys within the perinatal package, i.e. achieving all the elements, and those who did not, and what perhaps was done better, could be done better in babies who did not achieve, all the elements of perinatal wellbeing package with. I do the NDC clinic as well, so I get the opportunity to see the longer term outcome for these babies upon 2 years, and we share that message with the unit. The other thing we did was to kind of make sure that we flatten hierarchies. There are many of us who are neonatologists, but the people that are on the shop floor all the day, every time, the doctor, the nurses, the trainees, what do you think? How do you think we can implement these changes? And I think that with opening those hierarchies, allowing people to share their ideas and listening and testing them, we were able to getting success in delivering this package. working with parents, collaborating with parents. For example, in Wishaw, we have the Golden Drops Liquid Gold initiative for our breast milk, understanding what the barriers are for delivering breast milk within 24 hours and addressing those allowed us to get successes in that area. Now, the other thing we did around our processes was, how do we make delivering this package part of our everyday work, and how do we get feedback from when the package is not being delivered? So what we have done is, within our electronic patient record system, within our processes of attending deliveries, we made sure that at various standpoints there were checklists that were followed, either knowingly or unknowingly, that all fed into achieving the different parts of this aspect. So for example, we have a safety brief where you highlight the high risk deliveries that are going to come in that day, early risk identification, prompting people to deliver antenatal storage, prompting for magnesium sulfates for parents as well. And then we also went back all the way to antenatal care. How do we, women who are higher risk, speaking to them at the very offset, expressing breast milk, skin to skin, how this improve outcome, starting that education from that very point. And then in terms of delivering this package, we couldn't have done it without the obstetric teams and the midwifery teams. So it wasn't being confined to the neonatal unit. So allowing collaborative working across teams and within teams, open communication, changing culture, changing mindset really, really helped to allow us to get the successes, which I'm going to show with our data in the next few slides. I think as well, it's important to say that in trying to achieve success and waiting for the big shifts, we didn't lose focus about celebrating the marginal gains. If we were able to achieve three sets of neonates out of 5, we celebrated that success, let people know how well we were doing, to kind of fuel energy towards achieving it and moving forward in subsequent deliveries. So data, which I think is very important, but I think the behaviors around achieving this data is what I feel and we and Wishaw are kind of celebrating even more. Now, this is one of the first elements we have in the perinatal package, which is antenatal storage. As you can see, around about 2019, 2018, we're 100%. I think this is reflective of the number of babies that were delivered around that time. And also, we were a much more larger team at the time. And as more smaller babies were coming into the unit, we find that there were concerns about repeated doses of steroids being given to moms. So they come in certain label, they get steroids, they leave. And focusing on having those discussions with the obstetric team, we're able to kind of achieve, try to bring that number back up to around about 80% within and delivering antenatal steroids within the first 7 days. And what is important for us is going back to this data and being able to explain at each point what has happened. So, for example, I would say in June 2020, I know that this was a baby that was born before arrival. And are we able to change that? No, we can't. That had already happened before the baby came into the unit. So it's understanding this and using it to change our activities within the system to deliver the package. In terms of magnesium sulfate, reflecting what Lynsey just said, we were very, very, in the beginning, we were I would say it was quite challenging. And I think it's because of proper identification of patients who required antenatal magnesium sulfate, and also the newness of the knowledge at that time as to the importance and the benefits of magnesium sulfate in improving neuroprotection and in improving neurodevelopmental outcome. We still have significant challenges in achieving this in all babies, and most of this is reflected around babies who are either born before arrival or very, very quick deliveries, or where there has been either an abruption or uncontrollable factors most of the time. Our obstetricians are getting really good at this, and I'm quite happy to say that though we have outlying points, there's a general trend towards improvement from about 49% to about 89% over the last year and beginning of 2022. With regards to delivering the perinatal wellbeing package, delayed cord clamping bit, we have always done really well in Wishaw in terms of delivering this 60 seconds is what we try to aim at the minimum. If we can, if baby is called baby is vigorous and there are no concerns, we try to aim for higher than that. What is also clear from this is we have not had any points which are lying are outside our any astronomical points. I would say we have areas where around here in August, we kind of find around August, February, that when we have change in staff, sometimes we think that that impacts on how well we're able to deliver magnesium sulfate. So how we address this was with a team meeting between obstetrics and neonatal teams. And one of the ideas that came up was to have a magnesium sulfate pack within the triage. So for babies who present before moms who present at triage before they can be moved to labor ward and given their medications to actually create an environment where this can be delivered there in triage and then mom subsequently transferred to labor ward. And with that, we've seen this nice trend. So it has worked. And that idea was given by one of our ST trainees, obstetric trainees, which is one of the reasons why we have open hierarchies and acceptability for all ideas that come in. The nomothermia data, we have historically, we've done really well. However, like Lynsey pointed out, my initial fellowship topic was to improve nomothermia within our babies. And having a little PDSA, we found that actually they were all quite very warm. And so it's not a temperature less than 36.5. We were seeing babies that were 36, 37.8, 37.9. And so we had to kind of pull back on how well we were doing. You know what I mean? In these areas where we had the astronomical points here, these were babies who were born, a set of twins who were born before arrival, and then another baby who was born in the car park. In the 2021-2020 period, we had a 22-weeker, and I'm sure many of us will know that thermoregulation within this age group with gestation is quite difficult, and we were all learning. So reflecting on that, we now have a transwarmer within our delivery packs for babies who we know at the time of delivery are already having issues with maintaining their temperature, and that has kind of seen us trend forward again. So learning from our data, learning from our experiences, and going back to interrogate it immediately as soon as possible is one of our ways of delivering and achieving those successes. Caffeine, historically, many of our babies, almost all of our babies, as you can see from this chart, get their caffeine on within 24 hours on arrival to our neonatal unit. And interestingly, sometimes you see when you are a stickler to the rules, you can still kind of get things wrong. So these babies here are babies who were 29 or 30, 29 plus 6, and by the time they get admitted in the neonatal unit, they are more than 30 weeks. And so they don't get their caffeine around about that time. So we've kind of tightened that a bit. We will give you the caffeine even if you were born at 30 plus 24 hours or 21 hours. So that's kind of changed now, and that we have that nice 100% achievement for our caffeine rates. Right, this is, I think, across Scotland, and particularly within Wishaw, we have this trend of difficulty with maternal mom's own milk, and I think this is not solely to do with not trying on the unit, because we have lots of initiatives in place. We have an infant feeding midwife dedicated to the unit. We have an infant feeding team and breastfeeding team. It's more of a cultural thing, and we have identified that from speaking to parents and from historic data that we have. So what we have tried to do is, how do we catch this sooner than when babies and moms present to the unit? So we have initiatives within GP surgeries within Lanarkshire, where we have visuals, videos playing around and around on loop within the surgeries to talk about the benefits of breastfeeding, why it's important to mom, bonding, neural connections within the brain and things like that. But I must still say this is still challenging, but we're not going to give up on it. We're dedicating a lot of effort and I would say and funds to try to deliver this. And right now we have the Golden Drops initiative, like I said, which was developed by parents along staff with our staff midwives as well, and it's going well just now. So our challenges, I think, like most units within Scotland will have had over the last 18 to 2 years, is around capacity issues with people COVID, sickness absences, and also local culture. How do we keep changing people's minds and refocusing people, getting those early adopters and people who will run with the ideas? But more or less, I find that the trend is towards people, most of our staff and parents, I would say, being QI driven, wanting to improve what we're doing on a daily basis. As well, in terms of turnover of staff, we've had a huge loss of staff through retirement, and we find that being aware of the processes within the unit for the new staff takes some time, but that is with lots of induction and changing in our practice, having a period of supernumerary that is also coming, being addressed quite rightly as well. And in case of with the next challenge we have is competing priorities. There are lots of initiatives, we know that, within maternity, within neonatal, the same people trying to deliver on these different priorities. People get, I don't want to use the word burnt out, but people get overloaded with things to do, and it's trying to kind of ease and know when to push further and know when to pull back and support people through delivering various aspects of this initiative. Maintaining drive is another one. Data entry, I'm sure many of the units within Scotland now have the electronic patient record. We are fully electronic. The data you get is reflective of data you receive, the information you get. So it's trying to improve data entries. Most of the time, some of these aspects of our bundle are actually done, but if you're not recorded, it's not done. And unfortunately, that is what happens in real time. So we're trying to improve that. We're still trying to see if we can get a data manager, but as you know, we're trying to save funds within NHS. So these are people's peers being driven to that. So trying to improve that by making that part of our everyday processes. So now part of our ward rounds is reviewing to see that if this child has had this aspect, has it been recorded? Has it been recorded appropriately? And that is how we're trying to address those challenges. Now, for the next step for Wishaw is, we do know that our sole aim within Scotland, and I think with the neonatal world, is to improve perinatal outcome, decrease morbidity, and improve parental experience. You want people to go home with healthy babies that are alive, but you also want them not to be scarred by the experience within your unit. So what we're trying to do is extend this perinatal wellbeing package within the unit through our neuroprotection bundle, which has been developed by one of my colleagues, Dr. Mantasar and his team, BPD reduction as well, which also stems from MCQIC, but we've kind of given it a Lanarkshire twist, trying to see how we can improve outcomes from that aspect as well, decreasing infection through our CLAPSI work, and improving parental experience and collaboration through our swaddle, bathing, psychological services, and the rest of them. So our neuroprotection bundle, which we're going to extend into our perinatal wellbeing package, is to achieve a 30% reduction in our grade 1 and grade 3 and grade 4 IVHs within the unit, and through the use of evidence-based practices such as, and the basic principles is to decrease sudden and large pressure changes whilst managing these patients, particularly the very extremely preterm ones, through a midline positioning and head tilt around about 20 degrees or so, and 2-person techniques to handling this really extreme preterm, especially the less than 25 weekers. So in nappy changes, many of the times you have lifting of the legs to slip the nappy in. So trying to make it more stable, allow more positive touching between parents and babies, and between staff and babies as well. So this is a piece of work that is already ongoing, and we have definitely seen a 30% reduction from Mahmoud's work. Obviously, this is a whole package, not just because of the neuroprotection bundle, but driving it has also contributed to that improvement. And the next step as well is to try to incorporate within the perinatal package, within Wishaw, a BPD reduction bundle. And this is centered around the basic principles of looking at our delivery room practices, having indications and criteria for initiation of CPAP, initiation of intubation, and stepwise so people recognize when they should intervene, and risk identification and prognostication within the neonatal team. What we're trying to do is identify patients who we know are most likely be risk for BPD, so chorioamnitis patients who have not had antenatal steroids, and at various points having MDT reviews, 1 or 2 consultants seeing how these babies are hemodynamically, nutrition-wise, optimizing that, and trying to see how this improves outcome in the long run as well. So, and other next steps are CLAPSI as well, our road to zero. Right now, our CLAPSI rates are around about 2 per 1,000 line days, and we're trying to see, I know realistically we say road to zero, but we'll keep trying to kind of maintain that and also try to refocus our golden hour initiative, which is to hands off, admit, do all our procedures and hands off the babies around about an hour of age. So far, this is our journey with the perinatal wellbeing package. With still lots of room for improvement, but we are quite happy with where the staff are now in terms of team working, in terms of incorporating in our processes, and in terms of delivering on better outcomes for our patients. Thank you. I'd like to thank these people who obviously have contributed massively to delivering this within the unit, and to MCQIC for supporting us in delivering this as well. So thank you.
Thank you very much, Augusta, and it's for your fantastic, very comprehensive presentation. And it's clear there's a huge amount of collaborative work going on in Wishaw, so well done. Without further ado, I'm going to move on to our next speaker, who's Dr Jennifer Hendry from NHS Lothian. She's one of the paediatric trainees who I'm delighted to see is going to talk to us about their work on maternal breast milk and temperature. So I'll hand over to you. Thanks, Jenny.
Thank you very much. Good morning. I'm just going to take control of the slides. Perfect. So my name is Jenny. I'm one of the paediatric trainees in Edinburgh, and today I'm going to present some of the work that I've been doing in the Simpson Neonatal Unit, along with one of my colleagues, Laura Dunn, supervised by our consultant, Dr Becker. In Edinburgh since 2017, we've continually audited all our preterm babies born less than 34 weeks for compliance with the Preterm Perinatal Wellbeing Package. Over the 2021 to 2022 period, my work has focused on two projects that were already established within the neonatal unit. The first is Goldilocks, aiming for normothermia in our preterm admissions, and the second, Golden Drops, supporting maternal breast milk within 24 hours. And I'm going to talk about both of these today. So the Goldilocks project was first established in our neonatal unit in 2019. We wanted to make sure our babies were being admitted not too cold, not too hot, but just right. This project originally arose after we reviewed the BAPM toolkit on normothermia and process mapped the baby's journey to ensure that we're meeting every opportunity to achieve normothermia. With this project, we're now working at phase 5 of the QI model, where we're really aiming to embed this standard as the new norm. So during our preterm birth briefs, one member of the team will be allocated the role of Goldilocks champion. During the initial stabilisation and transfer of the preterm to the neonatal unit, it will be their sole role to ensure that continuous temperature monitoring is maintained and radiant heat is adjusted to ensure the baby is admitted to the neonatal unit normothermic. The team had also set up a sticker poster competition in the doctor's room that meant the team member that was allocated as the Goldilocks champion would receive a sticker on the chart next to their name if the baby was admitted normothermic. And by the end of the rotation, the team member with the most stickers would receive a prize. So with the rotational nature of junior doctor placements, it has been essential that we continue to repeat educational messages around thermal care to new team members. So in March 2021, we relaunched the Goldilocks project with a fresh poster for the competition in the junior doctor's room. And we also made new educational graphics, which you can see here on the right of the slide, to provide education on optimising thermal care. And these were shared to the whole team through WhatsApp, and they were also on display in the neonatal unit. And these resources have all subsequently been reused with new trainees as they've rotated into the neonatal unit. See from this run chart, our most recent data between March 2021 and February 2022 shows that we are meeting the NNAP standard of achieving normothermia in more than 90% of our preterm admissions, with our median sitting at 100%. And this has been an improvement in comparison to previous years. You can see from the first arrow that Goldilocks was launched in April 2019, and although we had seen some improvement with this, it hadn't been sustained. I also just want to highlight the green dotted line on the graph here, which shows that the babies that were admitted that were hyperthermic rather than hypothermic. And this now seldom occurs and is usually very mild when it does happen. So we believe that the ongoing success of the Goldilocks project and being able to meet this NNAP target consistently over the last year has been reflective of the cultural change that education has encouraged. Through the pre-briefs prior to preterm deliveries, we've consistently highlighted the importance of nominating someone as the Goldilocks champion, and this has allowed us to really encourage the whole team in the neonatal unit to work towards a shared goal and therefore embed it into our standard practice. We recognise for optimal success, quality improvement measures that are implemented need to be sustainable. We believe that the competition element with prizes has encouraged buy-in from the team and increased team enjoyment and bonding. Continual education and relaunch weeks are also essential for each new group of rotating doctors to ensure that the message is consistent and high levels of success maintained. So moving on to golden drops. We know from the preterm perinatal package that we're aiming for all babies less than 32 weeks to receive maternal express breast milk within the first 24 hours of life. And we've created golden basins that are given to all parents of babies that are admitted to the neonatal unit. These contain physical equipment to help expressing, but also educational stickers for parents with advice on good practice for expressing. We've also created staff cards with golden tips for golden drops. By sharing these cards to all staff groups, including midwifery, nursing and medical, we ensure that the educational messages are consistent throughout. We advocate expressing within 1 hour with a pump to encourage early priming, and we advise double pumping should be used from the outset. In order to optimise lactation, our tips suggest expressing should be performed 8 to 10 times within a 24-hour period and at least once overnight. So this run chart shows that between January 2021 and February 2022, our median rates for achieving breast milk within 24 hours have been around 55%, and this is a decrease in comparison to previous years where it has been above 90%. The green dotted line here does show babies that are receiving breast milk within the 72-hour period rather than the 24-hour period. And although there are more babies, we can see that it's still less than what we had been achieving previously. And we feel that this really stresses the importance of early expressing within 1 hour of delivery for the ongoing future success of maternal expression. It's clear from the data that we've collected over the last year that we're going to have to start again at phase 1 of the improvement journey and work through the BAPM toolkit on optimising early breast milk to help us establish what the barriers to our success have been. We recognise that there have been some challenges over the last year, and some of these have been out of our control. For example, we've had some extreme preterm deliveries associated with severe maternal illness. And due to the COVID-19 pandemic, we've also had lots of staff disruption through isolation and shielding, as well as new members of staff, which can affect the consistency of our messages. And unfortunately, our Golden Drops champion within labour ward retired during this time period, and we're definitely noticing the effects of the loss of her wonderful work that she'd been doing. And although the neonatal unit was reopened to having parents as visitors, visiting has remained restricted throughout this time on the postnatal wards, and we wonder if this reduced support for parents could have also made an impact. It is clear that this is a complex process and there are lots of different factors involved, and even if certain areas of care are going well, if there are challenges in one area of the service, it can affect the whole programme. It's essential that we have coordinated and sustained efforts across the entire perinatal team to make it easy for staff to do the right thing. We clearly need to collect more data about the barriers to change, and one of the ways that we aim to do this is by creating a pro forma that can be completed on our computer system track. This will be easy to fill out and will align well with workflow. It will be filled out by the midwife on labour wards and will include information about early expression and if this hasn't happened, why it hasn't happened. And it will also act as a reminder of our golden tips and then as a handover tool for the next member of staff looking after the parents as they move to the postnatal ward, so that they're up to date with what stage that the family are at in their expressing journey. And we hope through this we can gather valuable data on reasons why staff have or haven't succeeded. And through this information gathering process, we hope that we can identify problems and ensure that we're implementing targeted interventions for maximum success. So in conclusion, through our work, we've highlighted the importance of having a shared goal consistent across the whole perinatal team. In order to encourage this, it is essential to have consistent leadership to maintain staff awareness and keep teams focused on these shared goals. Continual review of data is essential. We must not become complacent when trying to achieve our targets. Although it can be easier to embed some practice change within the team, as we've shown through our Goldilocks work, there are some more complex processes that can take longer to embed change, and we must make sure that we don't take our eye off the ball. Thank you very much.
Jenny, thank you so much for your lovely presentation. It's great to see the excellent work from NHS Lothian, and certainly represents the challenges with turnover of staff, and having those people that are really driving those improvements, and the loss of those people can make a big difference. So thank you so much for sharing. So I'm delighted to introduce our next presenter, who is Dr Gemma Edwards, who's a paediatric trainee in Glasgow. She's also currently on her Scottish Clinical Leadership Fellowship. And very important to give her recognition for the lovely purple poster that we all see across our units, because it was her and her very talented brother who was very patiently waiting PDSA number 26, I think, by the time it was published. So Gemma is going to present some of the work at the Princess Royal Maternity. Handing over to you, Gemma. Thank you.
Thanks very much. I think it's my brother that deserves a lot of appreciation for the poster, because he had to endure a lot of, would you just mind slightly altering this slight thing for me? So he put up with a lot, but I hope it's been worth it. So thank you for having me here to speak. So like Lynsey said, I'm a paediatric trainee in the west of Scotland, and I'm a Scottish Clinical Leadership Fellow working with NES this year. So I'm going to speak about the preterm bundle work in the Princess Royal Maternity, and specifically looking at the rates of deferred cord clamping. So background, so as you know, the preterm perinatal package was launched in 2017, and this was work that began in the Princess Royal Maternity in Glasgow in kind of 2018, 2019, around about the time when I was a registrar there. So we could see that local data was showing there was a lot of variability in the uptake of each of the elements of this package in our local units. And we could see there was a need for improvement, a need for kind of clear and consistent messages, and better collaboration across obstetric and neonatal teams. So in doing this, we could see, looking at each of the components of the preterm bundle and the wellbeing package, we could see that a lot of these weren't just things that were in the control of the neonatal team. Lots of these factors, so particularly steroids, deferred cord clamping, and magnesium, required so much buy-in and support from the obstetric team too, and really required a lot of working together. So from the neonatal side, there was a team of consultants and trainees who were interested in working on this project. I suppose that made it complicated because trainees obviously rotate every 6 months, so there's a bit of loss of continuity there, but at the same time, every 6 months it's a chance for kind of fresh enthusiasm and new ideas to come into the work. There was also neonatal nurses involved who identified their enthusiasm in being part of this work, and there was an obstetric clinical lead for the work, along with members of the obstetric and midwifery teams who were involved in the projects. So the aims of the project were to standardise the management, make sure that there's clear and consistent messages being given out, so that regardless of what time of day or night, or whatever team was present at preterm delivery, it would be the same package of care that was being worked towards by every member of the team present at the delivery. And to do this, we knew we had to improve collaboration between the neonatal and obstetric teams, so that everybody was clearly working from the same set of goals and understood why we were doing this. And we realised that there's such a strong and important evidence base behind each of the elements of the preterm package that we really had to highlight the evidence base and exactly the benefits of doing these for the outcomes for our preterm babies. So our change idea was a preterm bundle, and really it was divided into 3 quite simple stages, so just the preparation, a pause, and the postnatal stages, so that we could be clear that everybody in the team had the same consistent setup for a preterm delivery as long as time allowed for it, a clear pause so that everybody had their roles, and that the pause was a chance to open up communication between the neonatal and the obstetric teams, and a postnatal focus that we could remember once we got a baby to the unit, there were still very important things that had to be done within a set time frame, and not to forget about these once we arrived in the units. So this is a copy of our preterm delivery bundle for all babies under 34 weeks, and very quickly, I think after the launch, this was quite quickly embedded into standard practice, and as soon as you knew there was going to be a preterm baby delivered, somebody would have grabbed one of these sheets, and it just gave you a focus to begin working from. And even if it was kind of the first stages of preparation, so that would involve working through what was going to be the team roles, what was the plan for respiratory management, and having a simple checklist of the most important items to have with you at delivery. And it was quite good, even although it looks like it requires a lot of preparation, even if you had very short notice, grabbing this gave you a very quick focus for what equipment you had to take with you, and everybody knew what we were working from. And then the second stage was the pause with obstetrics, and this involved collaborative work to make sure that there was a chance for the neonatal team to have their voice heard at the delivery of a preterm baby, introduce themselves and vocalise their priorities. And this involved adaptation of the WHO surgical checklist so that there was an opportunity for the neonatal team to speak to clarify what they wanted to be, so their priorities. So we spoke about steroids, we spoke about magnesium, we spoke about deferred cord clamping, and we also said as well that we would really like to have a delivery room cuddle if the baby was stable enough, and that we would provide support and guidance in doing so. And where this came into the deferred cord clamping section was that so if we were at a delivery, so labour ward or in theatre, you know, we would be in the middle of the room, we would have our chance to say we would really like deferred cord clamping, this is why, and we're not giving all the responsibility to you, we'll be here all the time, we'll support you through it, and we'll take ownership of the decision making around that time. And then the last section was the kind of postnatal. So this was just kind of to signpost to us that once the baby had been stabilised, we still needed to focus on temperature, caffeine, and begin to think as early as possible about maternal milk so that we could ensure this could be achieved within the next 24 hours. So this is just a picture of the team carrying out the huddle at the beginning of the preterm bundle. So this would be kind of the section going through the checklist and making sure all the equipment is ready. Whenever I was doing this, or one of my colleagues I saw doing it, we would usually be in the middle of the room for doing the pause with the obstetric team, and it just really opened up the communication. It would give you a chance to say, had we had steroids, had we had magnesium, just to reinforce how important this was to us, give a chance to highlight about deferred cord clamping and having a cuddle. I think as well as I would have been an ST4 trainee at the time, and I probably wouldn't have really felt very confident in jumping in saying, this is my turn to speak, these are the things that we would want to have at a delivery. But if it was an out of hours delivery and I was the person there, I felt quite empowered by having this bundle and this focus to work through, and nobody was surprised that I was doing it because the other trainees would be doing the same thing as well. So that was how it worked at deliveries. And then education, so we could see that there was a lot of variability in practice before implementing the bundle, and there's lots of different sections that I suppose aren't the easiest to always remember, so the different timeframes and different gestations, and we felt there was such a strong evidence base for each of these components of the package, but there wasn't a huge understanding of exactly just how beneficial these could be for babies, and we needed to provide more education for the MDT. So this involved creating more posters and awareness of the package, and running multiple small sessions which were for the obstetric and midwifery teams, just to continually reinforce these are the goals that we have, and this is exactly why it's so important. And this is our preterm perinatal package poster. Like Lynsey said, I think it's version 27, so I hope that you like it. But we want to have a message that was very clear and could be easily transferred between units, and it's been so nice as I've rotated through different units to see it up. And it means as well, as a trainee, as you're rotating to a different unit, you're not working with a different set of rules. You very clearly, you can see this poster up, you know that everybody is going to be working from the same kind of set of goals, and you know what you're doing. So looking at deferred cord clamping, we could see in 2018 that there was a lot of variability in the compliance with this, and we launched the bundle around about January 2019. You can see what the rates did following that. So we're really pleased that, you know, this is the rates for all babies, even the ones who would not have been, I suppose, eligible because there was placental separation or no signs of life. or needed significant resuscitation. So we could see a big increase, and this was really a lot to do with the communication that was going on at the time, and the neonatal team had a much bigger voice in talking to the obstetric team while this was happening, reassuring that this was okay and they were happy for it to still continue. So looking at this in figures of the uptake, so in 2018 there was 57% of all preterm babies were receiving at least 60 seconds of deferred cord clamping, and by 2021 this had increased, and this was for all preterm babies, increased to 80%. And looking at other sections, so for antenatal steroids, so the main figures were 75% of an uptake of 2018, and it's quite similar, it's 76% in 2021. The figures in the brackets are the mums who were receiving steroids at any point, so we can see that there was a good uptake of steroids, but it's not so often within the 7 days time frame that we would want within the goals of the package. And for magnesium, we also had an increase in the uptake of that. So 63% of babies of mums were receiving that, and that increased over that time period to 85%. And again, a lot of this was just continually vocalising the need for steroids, highlighting the benefits of it. And I think just because it was a much more widely spoken about thing, if as a registrar, if you were taking a phone call out of hours about a baby or a mum that had come in, you would be a lot quicker to say, and have they had steroids? I'm really sure this is what we would want to have at this gestation in this time frame. And just looking at other sections, so for normothermia, our rates were 78% initially, and then this was increased with a bit more focus on remembering about temperature once you got to the units, and also for supporting babies having a delivery room cuddle to make sure that their temperature was monitored during that time as well. And so 85% by 2021 were achieving normothermia. Maternal breast milk within the first 24 hours is something that still needs some work on to improve. So our rates had gone from 51% to 60%, so some improvement, but still an area that needs a kind of renewed focus. The keys to success were providing education on not just what we wanted from the elements of the package, but exactly why they were so important and what the evidence base is and how this could affect outcomes for babies. Standardisation, so making sure that the imaging and the posters and the messages between teams were very clear and consistent, and there was no variability in what standards we were all expecting. And so improving communication through cultural change, having the neonatal voice heard more clearly in the labour ward or obstetric theatre, even if it was a trainee that was the most senior person at the delivery. So challenges, so it was the neonatal team that were collecting the data, and it was really important whether there'd been successes or there was still areas for improvement, that this was continually fed back to the obstetric team, because it was their work they were involved in too, and they had to be involved in understanding where we were going with the data. Like I said before, so the uptake of steroids is quite high, but the timing is not always within the 7-day time period before delivery. There will always be the challenge of a late presentation of a mum in extreme preterm labour where there's not time for all of these elements, but I think we know quite clearly which ones we still can influence, even if it has been a late presentation. And like with lots of these areas, there's been significant challenges during COVID. I suppose the communication was impacted, particularly in theatre deliveries. If you were in full PPE, just that voice was maybe less clearly heard, and staffing challenges and changeover of staff too, trying to just keep the education going despite all of these different challenges over the last couple of years. So scale up of the work. So the preterm bundle is fully embedded into standard practice in the Princess Royal and has been shared and adapted for use across Glasgow. And then we've kept the branding as clear and consistent as we can so that it can be reproduced. I suppose from a trainee perspective, that makes it very clear when I go somewhere else. I feel quite confident. I still know what is going on, what the goals are, and hopefully this can be shared in other units too. next steps in the Princess Royal. So the deferred cord clamping rates were increased without the use of a life start machine, but we know that there's some babies who would benefit from having increased support and stabilisation, and that might increase the rates of deferred cord clamping further. So that's part of the next steps. Building on the collaboration across obstetric and midwifery teams, and identifying MDT champions, and just making sure that we're focusing on the other areas that are in need for improvement, such as steroid timing and maternal EBM in the first 24 hours. Thank you.
Wonderful, Gemma. Thank you very much. That was a lovely overview of the work at the PRM. Thank you. So we are going to move on to my predecessor, previous clinical lead, and now Dr Colin Peters, consultant and a clinical director for neonatal services in Glasgow. So Colin, welcome, and thank you so much for taking the time to present.
Thanks very much, Lynsey, and yeah, thanks for giving me the opportunity to talk about the work that we've been doing. Much of my slides will be overlapping with what those that's been presented before, so I'll maybe skip across some of them. But I suppose we were looking towards the end of 2020 as to what should our focus be. We'd had the launch of the BAPM antenatal optimisation toolkit, which had significant overlap with the MCQIC preterm perinatal wellbeing package, and perhaps not surprising given the Scottish involvement in that piece of work. But we also had the MCQIC NEC and QUIC BPD packages coming out, so we looked at what our next focus should be. And I will present some data here. As I've got a little message on the screen there, it's sort of unratified data at the moment, but hopefully it's helpful from an education and sharing perspective. So the antenatal optimisation toolkit has steroids, transfer from RAH to the Queen Elizabeth or PRM for lower gestation babies, antibiotics for women in labour, magnesium sulfate, parent discussion, evaluating for tocolysis, and delivery plans with a stamped acronym. The situation towards the end of 2020 was that our magnesium rates were about 70% in the Children's Hospital, and quite a bit of variability across the RAH and Princess Royal. Our steroid rates within a week of birth were in the high 70% in the Children's Hospital, and similar in the RH and PRM. These are the charts that are taken directly from the MCQIC toolkit, so they don't all have a median on them. Our DCC rates were somewhere about 70% at the Children's Hospital, and we can see there the success that has already been described in the Princess Royal, and the variability in Paisley given their low numbers. And from now on, I'll largely focus on the Children's Hospital data. The antenatal optimisation toolkit has a lovely driver diagram from which we've taken some change ideas, and we'll continue to develop those. So the preterm bundle B434 was a sort of development of the work that you saw that Gemma had presented based on the Princess Royal's prompt, and also developing a little bit of the BPD package in with that. We've tried to keep that consistent theme of the background pattern that matches the SPSP diamond shapes. The purple that represents neonatology, and the little heart 34 just came from the accidental typos that happen when you put into Outlook on Office Online. When you type in less than 3, it turns into a heart. So we've kind of got a little bit of a branding to try and keep that message consistent. As others have said, we try and have delivery of education to new trainees within a couple of weeks of starting in the unit, reinforcing the messages of birth at less than 24 weeks, magnesium sulfate for women who are going to deliver in the next 24 hours at less than 30 weeks, for steroids within a week in babies who are going to be born at less than 34 weeks, antibiotics, and this has taken us through the stamped acronym, at less than 37 weeks in established preterm labour. And we consolidated that into an A4 prompt, double-sided, with the elements of stamped at the top on the front page, then the items to take to delivery, as Gemma mentioned, and then the processes to be gone through. And that notion of standing in labour ward or in theatre and contributing to the conversation around why we would do deferred cord clamping, what would be the rationale for not doing that. Followed up with that process of reassuring the obstetric team that it's okay to not clamp the cord right now, a bit of stimulation for the baby's fine, and see if we can get through that first minute, whether that's on a life start trolley or not. And on the reverse side of the prompt, it has information about the things that we should be doing to reduce BPD, so the early effective CPAP, for example, and how and when we should give surfactant. So yes, there's the notion of what to do with optimal cord clamping, aiming for that 60 seconds in less than 34-week babies. And focus on maintaining temperature is shared with our trainees, thinking about the why and how to do that. So plastic bags for less than 31 weeks. And this is all on the prompt sheet as well. We have a sort of project within the project, contributing the Get Set program, so saturation, ECG and temperature monitoring, and the use of the Life Start trolley where that's possible. Continuous temperature monitoring, aiming to improve that admission temperature. Or express yourself in the children's hospital and let it flow at the RAH for less than 32 weeks is aiming to improve delivery of mum's expressed breast milk to babies in the first 24 hours, and the reasons why on your screen at the moment. We've tried to keep that branding similar, so we've gone for the yellow and the noting the similar message in Edinburgh and Lanarkshire of golden drops. We've gone with the yellow, but keeping that theme of the diamonds. And these screens are presented to our, or these slides are presented to our labour ward midwives on their rolling information screens, just to keep that memorable notion of the importance of it, along with all of the kit that's been described previously in Edinburgh. B434 at the end of the prompt, it tells us about things to be thinking about. So early caffeine after getting to the neonatal unit, thinking about research studies that we might be involved in at the time as well. So it's adaptable on a weekly, monthly, yearly basis. Our posters are up in labour wards, antenatal areas, neonatal units. And we keep the branding again with our respiratory bundle, with the blue this time, looking to think about early effective CPAP on the reverse of our prompt, and how we might deliver that. It goes on for us to be thinking about volume limited ventilation, and when and where to give surfactant. So prompting us that should the baby be intubated in the labour ward, that we should be giving surfactant there and then, and not waiting till we're in the neonatal unit itself. So in addition to the likes of Get Set and the BPD prompt and the Express Yourself, what other tests of change have we got? Well, for those of you that don't know our unit, our labour ward is on the floor below our neonatal unit, and you run down a stairwell to get there, or walk, I suppose. And at the bottom of the stairwell, there's a massive poster, still in a Blue Peter style of, and lots of joined up sheets of A4. But it has the things that are key at that point in time, the things that we are focusing on: optimal cord management and the why, maintaining temperature and why, and thinking about maternal breast milk, and that message shared as you leave labour ward with the midwife and the mum. We have a welcome to the neonatal unit prompt or a recording sheet developed by Ainsley Valentine, which has a number of our QI and family integrated care elements within that. You can see there just a checklist to see have they received their book by bag, their little inky feet instructions, but also in there, if mum's expressing, when was the first buccal colostrum given, and the aim to get that within 24 hours. So what's it meant for us? Well, our element compliance hasn't really changed at the moment. I'm hopeful that the last couple of data points above the median might be something to build on, but as a QI purist, I'm sure we can't take anything from those two data points themselves. But I'm hoping with a bit of post-COVID, hopefully, we'll be able to get a bit more engagement and improve on the element compliance. Magnesium certainly has got a shift in the last 7 data points there, so that's good to see, and let's see if we can get that sustained at the Children's Hospital, QE. Our steroids are quite variable, and I suppose that we need to really interrogate that. We don't have the case of having just a straightforward preterm presentation and delivery. we also have to be thinking about our complex fetal medicine cases who might, under monitoring, be deteriorating, and we think therefore we should give some steroids, but in actual fact they don't need to get delivered, and therefore we've missed that 1 week window. So a little bit of work being done around how do we identify those that are best to get it, but not miss the opportunity for those that are going to be delivered soon. Optimal cord management has had a bit of a shift towards the end of 2021, but we're back up towards where median is. So again, a bit of work to be done, and a reinvigoration of Get Set is going to help hopefully deliver on that. Caffeine, not a problem, as said before. And our temperature, again, this is where the focus on Get Set is going to come back in. It's not all cold babies, though some are. Some of it's going to be babies that are more warm than cold. Mum's breast milk has a trend within that towards the end of 2021, and Express Yourself hopefully picking that up. So what are our next steps? Close working with obstetrics regarding the likes of steroids and the other elements, reinvigorating Get Set with a focus on optimal cord management and temperature, continued Express Yourself work, and perhaps a better system for data collection so that we make sure that we've got a consistent message between what's being collected in the subgroups and actually presented within our MCQIC data. And a reasonably newly formed neurological injury group who are looking at some of the elements that have already been mentioned by Lanarkshire. And that's me. Thank you very much.
Lovely. Thank you so much, Colin. It's lovely to see this sort of passage of the same themes of work across the sister units in Glasgow. So thank you so much for presenting. Our final presenter is Kathleen Brown from NHS 9 Wales. We're going to be given a recorded presentation for Kathleen just due to lots of technical difficulties with her network this morning. So I'll hand over to the team who will load up Kathleen's presentation.
Hi, my name's Kathleen Brown, one of the consultants up at 9 Wales Hospital. I'm going to talk to you about our work with the preterm perinatal package. So following on from the last webinar that I spoke at with Shetty last year, we at that point had decided that the establishing of a perinatal team would be helpful in progressing the work that we were doing at that time. So we set about looking into that, putting out feelers to members of the obstetric and midwifery team, but also realised that having the theatre staff involved would be really beneficial as well for our sections. So we did that and found some enthusiastic members. We then established the goals of what we wanted to achieve in relation mainly to the perinatal package, but it did actually have, generate some further discussion. So we have initially focused on very specific goals with the prospect that this team will then grow. Once the team was established, we started spreading the word about the team and what we wanted to achieve, and thought about how we would maintain that momentum. So following on from that, our first success was actually establishing that team, and we were very lucky to have Dr Lauren Shaw join our team, who I'm sure most folk will know comes with a very strong QI background, and is just generally brilliant to have around. But also Mary Smith, who's one of our obstetricians, who also is very interested in quality improvement, especially for our preterm infants, which is great. So with those two joining, it really did strengthen the kind of foundation for that team. So with that team established, we were able to recruit other members and have had Teams meetings. We haven't actually met up in person yet, but the Teams meetings seem to have worked quite well so far. And Lauren helped create a driver diagram to focus on what we wanted to achieve as part of that team. In relation to the perinatal package, one of the things that we were able to establish quite quickly was a practical joint teaching session with role play, and some of you may recognise our simulated mummy, who was very up for it, and actually, although it did create some smiles at the time, it was actually quite beneficial just for the overall working and logistics of this session, and it helped create quite an enjoyable atmosphere, and we had medical, midwifery, obstetric, and somebody from theatre at that session. So that was good, and we've ran those a few times now and tried to do them quite regularly as part of our simulation. Also, something that stemmed from that team though is that we are much more involved with the midwifery education days, and there's been really nice feedback from the midwifery team around the sessions that were ran around the benefits of optimal cord clamping in our preterm population. So although midwives have been practicing deferred cord clamping for some time, there was identified a little bit of knowledge that maybe wasn't there for some of the staff around why it's so important in our preterm population, and it's not just that we're trying to be nice by facilitating in-room stabilisation, which is a very new thing to Tayside. With that generation of the team, there has and there is an ongoing feeling of team effort across the specialities, and there's generally now a neonatal presence with the theatre pause if there's going to be a preterm delivery, which is great because previously, because we were not part of the theatre team as such in Tayside, we're in a little room to the side, you can sometimes feel that you don't particularly know that team very well, but building those kind of relationships has been really good. There's been a noticeable improvement in our data in the areas that obstetrics have more impact, and previously that's been a bit variable, but the obstetric team are doing a lot of work as well themselves around steroids, what being given but also being given at the appropriate time, and the initiation of magnesium sulfate. There has been improved engagement from the midwifery and obstetric team with achieving optimal cord clamping, and I think a lot of that is down to engagement in the education days, but also that joint working and those joint simulation sessions. So in terms of the data, Lauren has pulled these graphs, so these are pulled from the quick data but put into quarterly rather than the monthly run charts, and I think it helps portray things a little bit easier. So the data is from 2018 right up until the first quarter of 2022. So our steroids, first of all, you can see that when we implemented the perinatal team last year, then things look like they've had a good steady improvement, which is lovely to see. Magnesium sulfate as well. So in the middle of 21, we were really not doing great. I'm not quite sure what happened there, but you can see generally we've pulled it back, and there seems to be so far a consistent improvement, which is great. Hopefully that can continue as well. Our deferred cord clamping is improving, and I think that is reflective of a few changes in practice. It's been a kind of steady encouragement, I'd say, of our labour suite team, and we'll talk about the challenges I think later on, but it has really been a massive culture shift for the team up here, and people that have worked in places where there is in-room stabilisation have really helped to foster the kind of enthusiasm, but also the comfort level of doing that, and just having a gentle encouragement at each time, and reiterating the importance of being in room to facilitate deferred cord clamping. which is lovely. So hopefully, and our median's changed, which is great. So hopefully that will continue. And I think it is starting to embed in practice, which is great. So these are our normothermic babies for our preterm babies less than 34 weeks. So it doesn't take into account the term babies in this one. But again, we are improving. So during the period of 2019 and then into the pandemic, we had a decant toward 31, and there was a little bit of a blip. We had been doing quite well after our continuous temperature monitoring, and then we moved, and there was issues with cold corridors and transfers. So we kind of re-emphasised our efforts and had pulled it back up a little bit, so hopefully good. We've now got our resuscitators, which is great. The little blip was round about the same time, and actually, although we weren't hitting the normal thermic, we've actually had very little cold babies. We had just ended up heating them up a little bit too far with our new resuscitators, but I think we're now getting the measure of where that needs to be, and there's some work around initial settings. It might actually be quite nice to see if other units that use the same resuscitators have had the same issues as well. So our main challenges was the initial engagement across the teams, because it really has been a massive culture shift for lots of the, especially obstetric and labour suite team, but even some of the neonatal team haven't worked in other units where the routine is for in-room stabilisation, but it is changing, and I think maintaining that positive attitude towards it and emphasising the reasons for doing it are really taking hold now, which is great. There has been a little bit of along those same lines, keeping momentum going for enthusiasm. I think it can be, we've noticed that it'd be quite easy just to kind of revert back to old practice if it's allowed too early on, but I think we've got over that, and really there is a shift now, which is great. We've made an effort to try and run our kind of simulation teaching quite early on when people rotate round, so it's mentioned at induction, but also actually having that in practice is good to kind of embed that with the new staff, both nursing and medical. And we now have a nurse educator appointed to the role after his retirement, who's really enthusiastic and really keen, so there's a lot of cross working, which is great. We do have still some challenges around the initial breast milk availability, but also some documentation around that, and one of the offshoots of that initial kind of driver diagram session focused on that. So there's a lot of kind of parallel work, I would say, with our infant feeding team around that, and hopefully that will continue to improve in terms of how we document that as well. But anecdotally, things seem to be improving, and there's a much greater awareness of the kind of early need for breast milk, which is great. So next steps, I would say continuing the momentum, keeping it going, and really, really embedding it into practice, which is getting there. Thankfully, now that we've got our full cohort of consultants, we're being able to establish proper weekly teaching, which had kind of fallen by the wayside due to service provision. But we've got that in place now, along with Kelly, our nurse educator. So hopefully that will continue to be a really positive experience. We're continuing our work in the perinatal team and just working on growing and kind of solidifying those working relationships with the maternity and midwifery staff, which is great. And working towards the compliance with the EBM less than 24 hours. So quite often we're managing to get the breast milk, but just over the 24 hours. So there's a real drive, and there's a big push by the whole team to improve that, which is great.
thank you, Kathleen, for that lovely presentation, and your run chart showing the impact that actual proper perinatal collaboration can achieve is really stark. So absolutely fantastic work. So we've eaten into a little bit of our Q&A time. So we'll move straight on to our Q&A. If I could ask everyone, and particularly the panelists, to pop their cameras on. And I welcome questions, discussions for our panel members, if anyone wants to pop their hand up or pop a question in the chat box. Oh, hi, Julie Claire.
I'm really sorry. I think with everyone's video going on, my internet's just gone a bit funny, but I just wanted to, a couple of comments. One, fantastic work around the country, absolutely brilliant. I am most excited, I think, by the work in Tayside about introducing a perinatal team concept. As you know, I'm chairing a group at the BAPM at the moment who's going to deliver a resource on how to improve perinatal team working around perinatal optimisation specifically in the summer, and it would be great to hear more from the Tayside about that. But MCQIC obviously have a fantastic resource which is called the Essentials of Safe Care, which deal with this kind of whole readiness for change and culture and team working. And I was wondering if Kathleen could comment about whether or not they'd used any of the brilliant sort of the fantastic sort of discussion cards that come with the Essentials of Safe Care that can be used to sort of help to establish shared goals and understand what might be barriers to better team working.
So we haven't used them specifically. I have seen it and they do look really, really good. I think one of the benefits we had was having Lauren on the team and having almost that that kind of feeling anyway, and those prompts that she brings. That she's actually managed to join. She was in a meeting earlier, but she has joined, so she might say a little bit more on that. So we haven't used those ones specifically, but definitely a useful resource.
Thank you, Kathleen. And I just wanted to say that we start our, I don't know if you've got Panda assisted here, but we start ours at 80% because they're absolutely fierce rather than 100%.
Yeah.
That stopped our babies overheating. So thank you.
That's exactly what we've done. Thanks, Julie Claire.
Really useful tip there, Julie Claire. Thank you. And I'm delighted that Lauren Shaw has joined us. Lauren, would you like to come in?
Hi. Yeah, thank you. So I would just say that how we started the perinatal team was really about asking questions. So we went down to our labour suite. We asked, because in Tayside, historically, we don't do in-room resuscitation, which we appreciate we're quite far behind in, but we really wanted to use that as a stepping tool for perinatal optimisation, so getting us into the room. And so we did spent a lot of time asking the midwifery and obstetric teams what their excitement or worries about that would be. So really trying to get the temperature of the room, and that was really useful in trying to understand what some of the barriers were. And a lot of it was just about, you know, why are they clamping the cord early? Is it because they're worried that would it be helpful to have us in there? And the resounding message was yes, they would like us to be in there because they need that added confidence. They worried a lot about space, and actually in reality the labouring rooms in Tayside are much bigger than say some of the other ones that I've experienced. So we could then give them that reassurance, and it just made for much more kind of open and honest collaboration. And I think that was part of the success of it ongoing. Thanks for presenting, Kathleen.
Thanks, Lauren. I agree. The Deferred cord clamping in PRM, the success was purely on that supportive team working element, that it was just this anxiety of let's clamp the cord, but we actually, when you stand next to the bedside, supporting them through those 60 seconds, that's an absolutely crucial part, definitely. I think we've got someone else coming in. I thought I saw a hand up there. Has it disappeared? Any other questions? I'm sure there's lots of thoughts. I'm hoping you're all kind of reflecting on what you've learned today and how you can take some of the work to your own units. Lauren.
Sorry, me again. I had a question to the other units. I missed the beginning conversations and might have been talked about already. One of the things that we've really struggled with is the early breast milk. And what we're trying to understand is it that mums are not given help to express? Is it that the milk is not getting to the unit, or is it that we're not giving it, or is it all around the documentation of it? And I know that we struggle to get consistency in where it's documented, and I wonder what other people's experience of that was.
I can certainly come in a little bit in that, and I wonder whether Colin from Express Yourself might want to come in as well. So I think probably all of those chain of events, Lauren, is impacting and the ability to get early breast milk. We took some of Anne-Marie Hookin and the team's lovely Express Yourself work from children into PRM, and there was so much motivation for it, the resources, the purple boxes, the kits. So the mums were informed, but I think it was the time then needing required to get the mums on the pump and expressing that has probably been the kind of downfall again with COVID absences, staffing challenges along the way as well. I also think the documentation of it has been really challenging, having to search through Badger, unclear if it's within the first 24 hours when it's on day 2, having to manually work through charts. So I think there's going to be some work with CleverMed to try and pull out a package and pull out that data a lot more easily. Colin, is there anything else you'd like to add?
Yeah, no, I think I totally agree with you. I had a very late night on Tuesday trawling through scanned case notes to try and find information for where in that and CleverMed will present as negative and positive imputation on day 2 of life. And the data I have probably doesn't match up with some of the QI work that was done. I know INNAP are looking at this early implementation of feeding, but it's likely, because of most units using a summary system rather than a full system, to be within the first 2 calendar days of life rather than the first 24 hours, which is what we felt. Oh, Julie Claire's shaking head. I don't know if we've got a mechanism yet. I know that the UNICEF baby friendly box allows us to record that, and that might be what they're going to take, but we certainly 24 hours is what we're aiming for, but it's a data challenge.
So Sam Oddie and Sarah Bates and Tony Kelly from Mat Neosip have been fantastically instrumental in the last 2 or 3 weeks in getting a timestamp on the first administration of breast milk, which is fantastic. We locally are working, and I'm hoping that will be implemented in the next couple of weeks, with our track system, so that we have got an early expression timestamp as well. Not timestamp, but did you support mum to express within the first hour after birth? And that's where we are going to collect the expressing data, but the giving it to baby will be on Badger probably with the next update.
Good to hear.
That's really clear. I certainly think joining up those conversations as well, because I've got in touch with CleverMed with regards to tweaking some of the ways that we pick out this data and how those data points are picked up in Badger is really important. So thanks for that. Augusta?
Yeah, Lauren, I think, like Lynsey said, it's multifactorial for us in Lanarkshire. I think mainly it's about the culture and the mindset of many of our mums, and from the little piece of work we did with our infant feeding team. So what we have done is try to catch them early in the pregnancy journey. So antenatally have lots of inputs there in the antenatal clinic. They have a feeding part of their clinic as well. But the other thing is, so, I don't know if that the wording of early expression. So expression, is it the same thing as delivering? So I think I'm just thinking about now, as someone said it, because if they express, sometimes they express, but it actually doesn't get delivered. So I think some of our data is actually not just the expressing, it's about delivering it to the baby within the 24 hours. So I think if we go back and look at our data and pull out just the expressing, you might find that our data looks better. But what we have been recording is actually expressed and delivered to the baby, because obviously that is where the impact is. It's not about it just being expressed. So making that more clear, I think, is also important. But for us, what we found, we have diarrhea rates, but they are coming up slowly, marginally. But what I think has really worked is catching antenatally and having a breastfeeding person within the unit to kind of help moms at that time.
Completely agree. Thanks, Augusta. And again, I think it's highlighting those challenges of sort of cross-specialty priorities between mum and baby as well. And a lot of these mums can be poorly after delivery, and the kind of priorities go to their clinical care. And sometimes that can be at the expense of time spent expressing. So definitely needed for some more collaborative joined up working. Can I bring anyone else in? Any further questions at all before we round up? Oh, I've got Andrew Guest. Would you like to come in? I don't know.
Hi there, my name's Andrew Thompson, one of the obstetricians.
Oh, hello Andrew, nice for you to join. Thank you so much for joining us.
No worries, I've enjoyed it. Some really, really good presentations. There's been quite a lot of discussion about corticosteroids.
Yeah.
And I guess I'd be keen to know, for those women who haven't received steroids, who didn't receive steroids within 7 days of birth, had they received steroids prior to 7 days? So I think one of the speakers said 76% had received, I can't remember which unit that was in the last 7 days, but overall, prior to that, 97% received steroids. I mean, there is limited evidence to support repeat doses of steroids, but there is evidence of harm. And the more recent college RCOG guidelines, they recommend a maximum of 3 courses of steroids. And NICE have been in touch with us just in the last week or two, saying that they'd be keen to recommend no more than 2 courses of steroids in total. So, you know, if a woman's had 2 courses, you know, the continual bleeder at 24 weeks, 26 weeks, 28 weeks, then we would be advised not to give a further course within the 7 days. I suspect that's a very few number of women, but I'd be keen to know that data. Thanks.
Yeah, Andrew, I would agree. I think that's almost the data that we need to pull back to demonstrate further need for improvement. The timing of the steroids is quite contentious, and I'm not aware of any places that are giving recurrent doses of steroids. I don't know if anyone, I think it's mostly just 1 full course of steroids within the 7 days. I'd be interested if anyone else is given recurrent dose, even for the little tiny babies with PPROM and or oligohydramnios. I've not really come across anyone getting recurrent further doses. Anyone else on that?
Lynsey, I can see that when we wrote the package, it was very much that it was the 1 course of steroids, and we weren't recommending a second course at that point in time. In particular, there wasn't the mechanism by which you should be achieving within 7 days.
Lynsey, and Tayside, what I noticed looking through our data was as our within 7 days increased, we also looked at the babies that had steroids, but more than 7 days, and there was also a really reassuring decrease in that. So as we engaged our obstetric and midwifery team, that data was getting, you know, the number of babies getting it after 7 days was decreasing at the same time, which was really nice to see.
That's good. And I suppose the QUIP app might help with that, hopefully, as that embeds through more of our units across Scotland, and trying to use that as a tool to try and more accurately diagnose steroids, because I appreciate with the RCOG guideline going live, there will be an increase in babies without steroids in those late preterm populations, so that will obviously have an impact on our units as well. So I have opportunity for one more question before we round up everything from today. There's someone else with a hand up.
Lynsey, we've got Peter Abels with his hand up.
Oh, hi, Peter, and you come, thank you.
Hi, I'm an obstetrician from Wellington, New Zealand, and I've come to Scotland in December last year. This is a brilliant package that you have. Wellington is the perinatal lead for New Zealand, and I'm just seeing everything in picture form that you have. It's just absolutely fantastic. I had the same questions that Andrew had, but as an obstetrician, you've answered that lovely. But would like to commend brilliant work. It's lovely seeing it and how it's implemented both at tertiary and at other levels. Just is fantastic work. Well done.
Thank you very much, Peter, and welcome to Scotland. It's lovely to have you, and look forward to working with you moving forward. Thank you very much.
Okay.
So thank you all so much, and I wish we had more time for some more discussions, and certainly will be future webinars to give that opportunity. If I could get the slides back up, I'm just going to go on just to highlight the key themes that I think have come out in all of our presentations that have really been the key to success so far. So we're seeing it everywhere, and I think actually Lauren and Kathleen's lovely slides of the annotation of the perinatal team and the sharp rise up in their administration of the various elements is really stark and a lesson for us all. So making sure that we have that full perinatal team involvement across the board, from right through that perinatal journey, from booking all the way through to postnatal care. And that has to involve all of our midwifery colleagues, our obstetric teams and our neonatal teams. encouraging champions across all of the elements, so obviously the leads within to provide that strong leadership, also having individual elements of the package championed across all of our specialties well, and I think these are definitely what we need to be driving forward to make sure that we get these gradual incremental changes. And let's not forget about co-production with families, getting their input into all of this, that the work that we are doing and we're launching is really, really important to make sure that it's targeted at family-centred and patient-centred care. Standardisation, so with the bundles being used across various units, I think you can see that by reducing the variation and trying to make a really high standard as gold standard across perinatal care, that is really the goal for mums and for babies. That ensures these teams are prepared, we are adequately planned, and there's that pre-delivery pause. So taking that moment, whether it's in the theatres or when it's in a delivery room, to have that open communication with our teams, making sure that the babies and the mum's well-being is prioritised, making sure we've done as much as we can to optimise that baby in that moment and to make that plan and support those teams through the delayed cord clamping. So that's definitely a key area to work on. And then maintaining that awareness, education, as we've seen through the purple poster, and the awareness of people's, making the awareness of the knowledge of all of these elements is just absolutely crucial. We have to target people's emotions and values to change their behaviours. And if they don't know the evidence, they won't change their behaviour. And the key to that is persistent education. And then finally, supporting frontline teams, having that really strong clinical leadership, which is visible, which is active, and which is supportive. Displaying your data through various means, and I've seen we've all used run charts slightly differently today, but making sure your frontline teams are exposed to that data, they understand that data, and they can act upon that data. Feedback and engage our teams to inspire that ongoing improvement. And it's about maintaining the awareness, maintaining that consistency in messaging. So, and just finally, a couple of things. We've mentioned the essentials of safe care, which are the core principles for safe and effective high quality care based on person-centred care, safe communications, strong leadership, and safe, consistent clinical care processes and pathways. There's some lovely resources online from previous neonatal webinars on a safety culture. But in relevance to the wellbeing package, we are looking at developing resources for person-centred care and safe, consistent clinical care processes. So I'll briefly talk about what's in draft. So we're working on further educational resources. So there's been lots of measurement to help guide our improvement, but we really want to focus on providing additional resources to share amongst the units to help drive and support those QI efforts. So backing up the poster, we're working on educational videos that can be shared and cascaded through all of the teams, that are just bite-sized videos that people can watch within their units that do not take much time. They can access from their smartphones through QR codes and various efforts. So these are all in development just now, and we'll be hopefully working with our CRGs and the teams across Scotland to help finalise and produce these, and we'd really value your input. Also, for those who have been talking about preterm bundles and prompt, we're working on pulling together a national bundle which can be used for your teams that would like it, and we're trying to embed this through electronically as well for those on full EPR, and that's again trying to provide a visual pathway for the wellbeing package and standardised care for preterm babies. And furthermore, we've looked at the data, and as I said, some of you are using lovely different run charts, but it's just about how do you feed that back to your frontline teams in a way that they can understand and appreciate it. So again, these are in draft form, but we're looking at monthly summary data, capturing all the babies that have been born premature, the level of prematurity, and looking at all the different elements. Where are they identifying the areas we need to continue to focus on? And that also shows the amount of babies that have been exposed to the various elements of the package. So these are all draft form, and again, we would really appreciate your input. So we've had so much to talk about, lots of fantastic ideas, and hopefully you're all feeling invigorated and inspired by all of the work going on around the country and how we can take this forward in our own units. So the aim of today, following this, is for you to try and reflect on what we've talked about and what can you take back to your units. And as I said, MCQIC will be there to support your efforts moving forward. Finally, a couple of things to flag up, dates for the diary. So we've got a PPH maternity webinar on the 15th of June, an Essentials of Safe Care webinar workshop within the neonatal community on the 2nd of August, a further C-section workshop by the maternity team on the 23rd of August, and our SPSP national event on the 27th. So it would be fantastic if we could get you to sign up for that. I will pop the QR code up for the feedback, and we'd be delighted if you could give us a little bit of feedback on today's webinar. While you do that, I will also flag up another important things for you to all share within your teams. MCQIC are currently recruiting to the Paediatric clinical lead post, and the deadline for applications is on the 29th of May. And really, we need to touch base with our paediatric colleagues to try and engage them in this work and their own, obviously, priorities as well. But would be really keen for you to share the link for the applications with your paediatric colleagues if possible. I'll give you a little minute to fill in your feedback. And also, just to flag up, there is our MCQIC SPSP members area, where you can access a lot of the MCQIC resources and the MCQIC data. And again, for those who are involved in QI or driving QI, we'd be happy for you to join, and you can access all the resources available there. So that's our members area. So just get in touch, and I think Halda will post the link on the chat for those interested. So thank you all again so much for taking the time to join our webinar. A particular thank you to all of our fantastic presenters who have taken the time to pull these lovely printed presentations together, and what is really flagging up the fantastic work going on around Scotland, and hopefully we can all take little bits from each other and implement it in our own units to drive ongoing improvements. So thank you all again. It was a pleasure to see so many of you on the call, and we will be in touch and see you all soon. Thanks, everyone.
Thank you.
Thank you.
Thank you, Lynsey.
Thank you very much.
Thank you.
Thanks very much.